Good morning, everybody. Welcome from Seattle, from the Seattle Science Foundation, on another overcast, smoggy day. My name is Jens Chapman, and today is September 16, 2020. Welcome to our STED Talk Spine Technology Education Discovery and Discussion. And today's topic is going to focus on neoplasia. We have a great guest speaker from the Mayo Clinic. I'm going to introduce him later. He's going to join us in a second. He just texted me that he has an acute case to evaluate. But we're going to hear about some new technologies, and that specifically goes around carbon fiber rods. I'm going to start with a case of a cervical thoracic junctional metastasis. So this is a 64-year-old female, and I'll wait for the screen to show up. And she has a history of breast cancer. She has severe neck pain. She has bilateral mild lower extremity weakness for about 24 hours. And she said bilateral mastectomies about 4 years ago. So this is something that we're seeing far more often these days. She's been on tamoxifen. And again, this is a common problem. So I'm going to maybe ask Dr. Askuyan to help moderate in the room, maybe ask one of our fellows what they would do with this. So this is a very common theme now. We have patients with metastatic disease that live longer, live better qualities of life than ever before. And then they usually on Thursdays or Fridays show up in an ER with this situation. And I'm going to just say the following thing. The normal standard of care is to give a patient with a neoplastic disease a biopsy. But here it's a Thursday night or Friday night, and this patient comes with this kind of a disease. So, Rod, do you want to ask one of our fellows, or do you want to... You have to bring the microphone to them, though.
Yeah, I'm going to ask one of the fellows. So I'm going to ask Dr. Gayumi, what's the... so this patient presents to the ER. It's 7 o'clock at night.
Friday.
On Friday
night.
And what do you want to do? She's got, it looks like mild weakness. So what's your plan?
Well, obviously, I would definitely go in and evaluate the patient, and given that if the weakness is acute, definitely admit her and do a whole exam, make sure there's no urinary bowel incontinence. If it's just weakness, I don't think it's something that needs to go in the middle of the night. But otherwise, this definitely needs surgery, needs to be decompressed. There's evidence of significant cord compression and kyphosis at that level.
So every single tumor course, including our great tumor course, which is, Rod, when is our tumor course? You have to say it in the microphone, though. When's our tumor course?
September 24th, I believe.
And who's going to lecture at the tumor course?
We have an all-star faculty.
Yeah,
So,
Dr. Hudi Mendel,
Yep.
Dr. Pachel, multiple great
Dr.
people.
Meyer.
Dr. Meyer from Germany
Yeah,
is going to
from
talk about carbon fiber rods.
26, sorry.
September 26th. So this is the case in hand now. Every single tumor course, Dr. Gayumi, will talk about biopsying first. Are you going to do that here? Or is the history that the patient had bilateral mastectomies 4 years earlier sufficient for you? Can you just briefly describe what you see on those glimpses of a CT and MRI that I'm showing you?
Absolutely. And the imaging, obviously, there's evidence of kyphosis. I have to...
Microphone to the mouth.
Hello. On the CT scan, there's evidence of destructive changes of the vertebral body. Does not look like it involves the end plates, which is typical for tumor. There's evidence of significant compression on the cord at that level. I have to count exactly to see what level it is.
I think it's T3.
T3. Yeah, there's evidence of junctional kyphosis at that point, at that level as well. In terms of biopsy, again, given that patients having acute changes, we were taught, again, in orthopedics that always biopsy. Don't assume that just because patient has history of a breast cancer, there's going to be a metastatic cancer. But I think this needs to be decompressed and probably can send samples intraoperatively, either as frozen and decide them. But I don't think I would wait for biopsy for this.
Okay, so the oncologist comes by and says, "Listen, we can radiate the patient first thing Monday morning." So what are you going to say when they bring up radiation?
Again, given acute changes and acute motor changes and exam changes, I think this needs to be decompressed. I don't think this is something that can wait till over the weekend for radiation.
So how do you grade this? Is there a system classification system that people use?
There's a SIN score for metastatic tumor cancer. I have to look up exactly what the categories is, but I think the amount of compression, neurological deficits, I have to look at it to be able to calculate what the score is.
So this will be it'll get a high number, right? It's in the kind of junction area, neurologic deficit. There's a
Lytic.
structural component to it. Lytic, and
Pain.
So I think that really helps, because what you'll see is a lot of the oncologists and the internists will, they'll say, oh, this is radiosensitive. We'll be able to just zap it, but they don't think about the structural instability, because once you radiate it, they're going to have a big hole in the spine. So there's going to be a structural component to it as well.
So, Rod, do you want to talk to somebody else?
Yeah,
So good answer. So SIN score has basically multiple components to it, but lytic lesion is one of them. Destruction of the posterior elements is one of them. Pain is one of them. Neurology is not one of them. And deformity is one, because the patient has kyphosis. So this patient is definitely above 11. And junctional zones, as Dr. Oskurian immediately said, is very bad. Why are junctional zones so bad? Who's getting the microphone?
Ravi's on the hot seat.
What's the problem with junctional zones?
Well, junctional zones, one issue is you definitely don't want to end a fusion in a junctional zone.
No, we're not talking fusion. Why are junctional zones so difficult just from a spinal column standpoint?
They're under increased biomechanical stress.
Bingo. Craniocervical, cervical thoracic, thoracolumbar, lumbosacral. They all have tremendous stresses on them. Okay, good. So there's not how would you brace a patient like this? If the internist said this patient can't go to the OR, what would you do to brace this patient? What kind of a brace is there to stabilize the cervical thoracic junction?
You could do like a CTO brace, like a cervical thoracic.
CTLSO.
Yeah.
Is that a very restrictive brace?
Yes.
That was a leading question.
Yeah.
Quite. So the good ones actually really arrest the skull base and the chin and have a very tight-fitting TLSO to try to have a biomechanical effect. Can you reduce a kyphosis with a CTLSO or a Minerva-type brace?
No.
Not really. So this is an area that is notoriously difficult to brace. There's a lot of cantilevering. And what organ structure causes that cantilevering effect on the cervical-thoracic junction?
Say that one more time.
What causes the cantilevering effect? What causes that biomechanical effect on the cervical-thoracic junction? Hint, you're a neurosurgeon.
Oh, the head?
The head.
Okay.
How much does a head weigh? Ravi, you're a
22
neurosurgeon.
pounds.
You're a neurosurgeon. You got to
Yeah.
be able to just shoot that out. The head causes that. The head's a big thing. It's a bowling ball on top of this Q series of ice cream balls. So this is a big deal, okay? There's a lot of weight on that head. So that's why this is a problem. Okay, so we have a very difficult to brace area. So let's move ahead a little bit here. So the question now is, should we torture somebody else, Rod, or is
Yes, and then we got Dr. Elias is going to load us talk. So let's go with WashU. We're going to go with WashU.
Dr. Rick Price from Washington University. So I put a couple of things down. So it's Friday night. As usual, you got a couple other consults in the ER. An epidural abscess here. There's a geriatric odontoid fracture. There is an osteopenic insufficiency fracture with a patient with questionable delirium and dementia. So how do you time this? Do you prioritize this patient or do you wait until Monday morning? Do you brace this patient, as difficult as it is, like what Ravi had just pointed out? Do you want to play it by the book and biopsy the patient? Or do you give in to the suggestion that Monday morning might be sufficient for radiation? Because the alignment is not that bad.
No, I don't think the patient needs a biopsy. I don't think there's a concern for primary tumor here in the spine. I think the story of history of breast cancer, the lytic lesion causing a neurological deficit, this is an urgent problem that needs to be dealt with over the weekend. I'd give the patient steroids and post him first thing Saturday morning.
Okay.
Decompress and stabilize the spine.
Now, this is always unfair, these kind of case presentations, because I'm just showing you glimpses. Comparing the MRI and the CT, is there something that concerns you on just these two little vignettes, these two glimpses?
The kyphotic deformity and the destruction of the posterior elements.
Bingo. So just right on these two pictures, you've picked up on the cardinal things. There are no posterior elements in there. Just for the viewership in general, what do the posterior elements in the spine, wherever we look at it anatomically, do? What's their main biomechanical function?
To prevent kyphosis, to keep
Tension band. It's a tension band surrounding the fulcrum of the facet joints, okay? So that's gone here. So the thing that I wanted to point out between the MRI and now the CT is that there's a significant kyphotic subluxation that's taking place between T2 and T3, and there's nothing in the back holding it. So this is an expected worsening. So just look at the changes on the MRI. This patient actually did not get immediate surgery. This patient was actually left in the hospital for a couple of days because they were actually planning on doing radiation. So these are some of the issues here, and Elias, your talk is downloaded. So let's come to a conclusion. Rod, you're a senior neurosurgeon, you're the chief of our spine service, so T3 is a problem zone. So what would you say in terms of Friday nights? You've had the usual 3 or 4 consults in the ER. Some are maybe non-surgical, maybe surgical. This patient is in misery. Would you basically, how would you approach this? This is a palliative approach. Would you do this acutely, like the next morning? And how would you get to T3? This T3 level is gone, so the patient is subluxed. So what would you do for this?
That's a great question. So I probably would do this the next morning, and I would do it posteriorly, and I would go probably 4 levels above and maybe 5 levels below, get good caudal and cranial fixation, and then I would try to core out as much as looks like T3 and T2 probably need to go. That's a very difficult area to get to. Historically, if you go anterior, you'd have to do a manubrial window or open the sternum, which is pretty
like this?
Morbid, yeah. Which I've done, but I think, given everything, I think you can take the T2 nerve root, you can spare, obviously, T1 and take T3 if you need to, and get pretty good access. We've done several of these together where we got, 2 or 3 level vertebrectomy and was able to slide in an expandable cage and do it all from posterior. The only thing, Jens, I think I've switched in the last few years is I use a Jackson table with Gardner-Wells tongs because I like to have the head a little bit mobile. And so what I'll do is I'll switch from, and I'll put it, once we take all the bone out, then I'll put the Gardner-Wells tongs and have the cranial so we can get a little bit more correction. But yeah, I think you can do it all posteriorly.
So this is something that still puzzles me. There are a lot of surgeons who really think that you have to go anteriorly. They're somehow uncomfortable doing a costotransversectomy at the cervical-thoracic junction, under sparing of the T1 roots. What's the lowest you've ever gone from the front to successfully place a cage from the front without having to split the sternum?
I mean, I think it's hard to get to. Usually, you can. That's a great image. I think T3 is too. Depends on the anatomy, but I can't get any lower. I think T3 is as low as you can go.
Have you ever split the manubrium?
Yeah,
It's a devastating procedure. It's not easy.
For the cardiothoracic guys, it's not a big deal. But when you hear that saw, the sternal saw go, you really start to think twice about it. You're like,
yeah, most patients have pain at their really manubio-clavicular joints, sternoclavicular joints. They always hurt afterwards. So anterior access is limited, and again, some patients it's really limited down to about C7 or T1, and others you can get down to T3, but it's not a predictable access. And how do you plan for an anterior access in terms of if you want to go low? What studies can we use to try to plan for an access?
Yeah, I like a CT of the chest. We'll give you a good, on the sagittal view, you can really see it. And then we're really fortunate on this campus. We have great cardiac surgeons. And so they're available. I've done probably about 5 sternotomies and manubrial windows since I've been here. And they do a beautiful job of getting you down there. But like you said, the cases I've done, I mean, one patient had a pretty significant amount of pain afterwards, but they all did fine. But when I look back on it, I think we could do most of it posteriorly.
So I suggest we come to a conclusion. So I actually took the patient to the OR, I think within a couple of hours of arrival, because she had actually subluxed, she had been on the floor for a couple of days, and she actually deteriorated. Of course, I would be amiss in not saying we did a full neural axis scan, so an MRI brain, cervical, thoracic, and lumbar spine. We've got a chest, abdomen, pelvis CT, and we got a full lab workup. We did an excisional biopsy, and we did a 2-level corpectomy, pretty much exactly what you said, T2, T3. And we went 3 levels above and 4 below. Why would we go 4 levels below? Can you bring the microphone to maybe Dr. Elias, who has loaded his talk? Why would we, Elias, come here next to me. Why would we go 4 levels below? 3 above, 4 below. Is there a logic to this? Talk to the microphone.
Well, the case I will be presenting is 3 levels above, 3 levels below, not 4 levels below.
So why did I go 4 levels below? What's my concern?
For the pull-up.
Talk a little bit further. What's in the thoracic spine? What's the structure we're kind of worried about?
Again, what level is it?
It's the thoracic kyphosis. So we always worry about the thoracic kyphosis. We ideally kind of don't stop there. So my judgment was that in her case, this is basically 4, 5, 6, 7, that I would have an anchor in the kyphosis, but that's a weak spot of my construct. So that's my concern. So either you stay above it or you kind of get into the kyphosis or just a little bit below it, theoretically. So I was lucky. I actually braced her after surgery. But in an osteopenic patient, certainly you want to be conscientious of where you stop your instrumentation. So that'll be a question for our visiting professor later in terms of how low to go with these carbon fiber constructs, because this is a difficult anatomic area. The patient actually did very well. I saw her 2 years out, and again, she got multimodal therapy, and she actually did quite well. So where's the escape button in this keyboard? And show. Are you ready?
I'm ready.
Looking forward to seeing your case now. And we have, just so you know it, about 10 minutes time.
So, good morning. My name is Elias. I'm a neurosurgeon from Lebanon. I'm a spine fellow at Swedish. Sorry for the delay. My USB didn't work initially. So I will present today a case, an unfortunate case of spinal tumor who got a double hit, one from the tumor itself and one from the pandemic. So this is a 79 female. She has multiple comorbidities. She has breast cancer. She was also discovered to have this retroperitoneal abdominal mass. She had resection in 2015, and it turned out to be a leiomyosarcoma. Post-resection, she had radiation therapy over the T10, T11, and T12 area. So this lady, after resection, 2 years in advance, she had a metastasis to her T3 level. Here you can see the T3 level with some epidural metastasis, also along the T8, T9, and T10 area. This is another slide showing the T3 mets along with severe central stenosis over this area. So she was seen initially by an outside physician. He elected to go for T2 to T4 laminectomy and T1 to T5 fusion.
So leiomyosarcoma, what do you know about that disease? And if you apply surgery, how do you stage that relative to radiation? And what are the excision criteria that you'd like to apply?
So
Mainly
mainly,
questions. Sorry.
yeah. So mainly, you would try to go for complete excision, like local leiomyosarcoma. The disease-free survival is around 60% or 60-65%.
Is it tied to radicality of the excision, of the resection?
It is. It is tied to the radicality of the excision. And if it is like, in this case, the disease is already metastasis, so she will have a poorer prognosis, and disease-free survival over 5 years will be around 20 to 25%.
What is your understanding of the literature in terms of timing of surgery relative to radiation? Do you radiate first and then operate, or vice versa?
So mainly depends on the neurological aspect of the patient. So this patient, she had a T3 compression with central stenosis. She presented to an outside institution, she wasn't here. Based from the notes, she had some weaknesses and she couldn't walk. That's why they elected to go for surgery.
So, in an ideal world, and we obviously live far from that, what would you have done had this patient presented to you with this image that you're presenting right now?
Yeah, so mainly I wouldn't go to the junction. I wouldn't stop at the junctional level. I
So
wouldn't.
mechanical consideration, yeah.
Exactly. So I wouldn't stop at T1, especially it's a junctional cervical thoracic level, and I would go like maybe I would extend it to the upper cervical level and.
So the length of the construct you're critiquing, but what about the resection? What do we see here? What does this look like? What was done?
Yeah, so he did like partial vertebrectomy. He didn't do any corpectomy over here, and
Yeah.
this is a good point because I will go back to this again. So he didn't do total resection of the tumor in here.
Yeah.
He did only decompression, and he just put some screws. And
So what do you think the tumor cells did when there was surgery done in there?
He
They
spread
would
he spread more tumors.
Exactly. The tumor cells go like, whoa, now we're pissed. Now we're gonna
Now we're
really get
free.
angry. So how long, so what happened next? Let's go there.
So patient was followed up, and unfortunately she had another metastasis over the T11 area with also some stenosis. In the retropulsion here you can see the central stenosis. Again, she was taken for another OR by the outside physician, and she had a T7 to L3 fusion with with T11 corpectomy and expandable cage insertion. So, Dr. Chapman, since you were asking me about the cervical management, this was the follow-up on this patient. Can you see the slides?
So Lee, we have a problem with our projector here. Okay.
Yeah.
So basically, verbalize whilst Lee is getting that established. What's going on here now?
Yeah, so this is the follow-up after she had both the cervical, upper thoracic and lower thoracic surgery. And as you can see, the CVA of this patient is 7, so she started to incline or to lean forward. And this is later or further follow-up, and as you can see, the SVA now is 11 centimeters. So this patient was seen now here in Swedish, and she has a kyphosis. She is now weak. She can barely ambulate, and she has a recurrence of the tumor over the T2, T3 area.
Yeah, almost
So as you said,
expected.
that he didn't do like complete vertebrectomy or complete tumor resection, and he didn't do a long construct. So she kyphosed, she had recurrence of the disease, and now she's weak. So unfortunately, this patient, she came during the peak of the corona or the COVID pandemic. Yeah, and and you couldn't operate on her here because of the corona restrictions. So she came weak and she came paraplegic. Okay, so a decision was made here to revise the whole construct. And she had a total revision from T1 to L1 with correction of her kyphosis.
So what are the learning points? What are the summaries?
So take-home message is once you have a metastatic tumor or a vertebral tumor, you should go for complete resection. You should not stop at the junctional levels. such as cervical, thoracic, and you should go for long construct to prevent further kyphosis in the future and to prevent future metastasis.
So I agree with a lot of what you said, but I think that in terms of metastatic disease, if I heard you right, you don't have to have a radical resection for most metastatic lesions. So this is a metastatic sarcoma. And again, for this kind of a sarcoma, this is a great case example of having a multi-specialty panel help with the decision-making in terms of adjuvant and neoadjuvant treatment, meaning chemo, immunotherapy, and radiation. What kind of radiation? There are multiple different radiation variants, which will play a role in the talk that we're about to hear. And in terms of the radicality for section, for most metastatic diseases, a decompression and a reconstruction as needed for biomechanical purposes is fine, but there's certain lesions that clearly need a radicality of resections, such as many sarcomas. Understanding what you're dealing with is important. That's where biopsies still have a role. It's a great case. The patient unfortunately didn't do very well, but it's a very educational case in terms of showing that if principles are not applied, surgical intervention is a problem. So thanks for getting that out there.
Thank you.
Lee, do we have our guest speaker? Thank you for showing that. So, again, my name is Jens Chapman, and I'm going to take my mask off. We have Dr. Maziyar Kalani here. He is from the Mayo Clinic. He's a neurosurgical colleague, and he did his medical school and neurosurgery residency training at Stanford, did an orthopedic neurosurgical combined fellowship at the Cleveland Clinic in complex and reconstructive spine surgery. And he specializes in a wide plethora of spine practice challenges in the degenerative arena, but also in deformity care. A particular focus of his has been oncologic surgical care. And again, this is something that's a growing field as our population is getting older and sicker, and has also far more success with treatment of metastatic disease. Newer biomechanical and engineering advances have allowed novel materials to come in. Dr. Kalani, one of the things that we just showed is a lot of metal around the cervical thoracic junction. So, Dr. Kalani, can you hear me?
Absolutely, yes, sir. Thank you. Good morning.
You come across loud and clear. It's nice to see you. Thank you so much for joining us. Very brief comment. You can answer it later also after your talk. It's your choice. We showed a lot of metal intentionally around cervical thoracic junction and around deformity correction. So I don't know whether you want to take that now or answer it later, but these newer biomaterials, are they able to handle these kind of complexities of multi-level disease, deformities, and cervical thoracic junction?
I think actually maybe addressing it at the end would be better, because I think the talk that I'm going to give has some of those points within it in terms of addressing the biomechanics, in terms of addressing material science behind what's going on. And it may change the question to a degree, but it may also answer the question along the way.
Sounds great. So we'll share the screen, and thanks again. We're all looking forward to your talk.
My name is Maziyar Kalani. As Dr. Chapman said, I'm from the Mayo Clinic, Arizona. By the way, perfect pronunciation of the name. I know it's a little bit of a challenge for the first time, but thank you for that. What I'll be talking about this morning is the use of carbon fiber instrumentation in spinal oncology, and why that's a paradigm shift that is happening, and at least should be considered in the back of everyone's mind when trying to determine how to take care of patients with spinal metastatic disease, but also patients with primary diseases of the spine. So the primary goal of this talk is to highlight technology. It is not to show really weird, really cool cases or say, look what I did, but mainly to talk about what the role of carbon fiber technology is in addressing spinal metastatic disease, spinal primary bony disease. These are my conflicts. And I'm going to start off by talking about what the role of the surgeon is in addressing spinal disease. So as the surgeon, of course, this is probably a little too deconstructed, but we decompress neural elements. So whether patients present with epidural disease and cord compression, or epidural disease and nerve compression, we're able to remove the disease. Sometimes, more often than not, we're also called in to stabilize the spine, whether it's to address the biomechanical uncertainty of the spine, the inability of the spine to bear loads, but also to address any pathologic deformity, very similar to the cervicothoracic junction case that you showed. And more recently, as local disease control through spinal stereotactic body radiotherapy becomes popular, we're being asked to treat essentially asymptomatic patients with epidural cord compression that need separation of the tumor from their cord in order to facilitate very high doses of radiation. And the reason that's more and more relevant is because the minimal doses of radiation needed to treat the metastatic lesions are almost always higher than the maximal spinal cord tolerance necessary. So the role of the surgeon to go in there and decompress essentially an asymptomatic neural element and also stabilize the area, because the treatment is inherently destabilizing, allows enough room to be there for the radiation oncologist, the radiation physicist, to be able to treat local disease and prevent hopefully recurrence and subsequent worsening of deficits. So what are the relevant issues for us as spinal oncologists? So wound healing is a very big issue. A lot of times, depending on where we practice, the practice patterns, the referral triages, we tend to see a lot of patients who've been radiated, who are presenting with issues. Sometimes that Thursday or Friday patient that Dr. Chapman was talking about has already been radiated or was radiated a few weeks before and is presenting late night as a pathologic fracture. So working in an inherently tough to heal environment is a big deal. So being able to address this, and I'll talk about this a little bit later, up front becomes more and more relevant. Of course, surgery is just a step in the process. We are not the end-all be-all for the treatment of these patients. Unlike a lot of other issues in spine care, the spinal oncologist is truly just a person along the continuum of care. And therefore, knowing that the next steps in terms of giving patients good outcomes requires not only imaging for follow-up, if we're dealing, for example, with young folks who have long lifespans ahead of them, like primary tumors, or maybe, for example, a young lady with primarily bony disease, or some of these patients who have very good response to immunotherapy. We're going to not only need to image them for their radiation planning, but also image them to be able to follow up in their care. And of course, maintenance of fixation is a big deal. A lot of these patients, almost all of the metastatic lesions, will go on to get radiation to their field. So as patients are able to live longer and longer lives because of good immunotherapy, good chemotherapy, and good radiation, we're having to deal more and more with the consequences of their systemic therapy, which is typically as relevant to us as non-union. So fatigue resistance, so the biomechanics, and I'm hoping the issues that the question that was brought up can be answered here, or at least maybe it'll change in your mind how the question that you're thinking about asking. So fatigue resistance is very important, and that's mostly to that last point of the biomechanics. So despite being able to fixate in the area, there's really no great way to hold our fixation in place, so to speak. So that either it's because the area has been irradiated and is now infiltrated with fat and bone marrow and within the bone marrow, or it's going to go on to get radiated, and therefore it's going to eradicate a lot of the endogenous signaling molecules necessary to create a arthrodesis. On top of that, because the nature of the disease is secondary lesions to the bone, we can't use the patient's own bone to help augment any of the arthrodesis, and other adjuncts such as BMP are generally relatively contraindicated within this population. In addition to that, most of these folks are essentially osteoporotic by nature of their disease infiltrating their bone and replacing their bony architecture. So we can expect failure more and more as these folks live longer and longer. So that's where the carbon fiber technology comes in, because it helps marry two of these big issues, which is imaging, as you can see, comparing titanium on the left with a CT scan, big starburst pattern. Imaging is very crisp. The halo artifacts related to titanium or metal artifacts in general on an MRI are also negated. And on imaging, you can see that it's relatively radio opaque. There's some translucency that allows A lot of folks like us who are traditionally trained with titanium instrumentation, with metal instrumentation, who like to see their screws, are able to still see the overall instrumentation on plain film X-ray intraoperatively. So this is what the construct looks like on a sawbones model. You can see that there are end caps going in through traditional pedicle screw trajectories. They're connected with top loading locking elements and connected with a carbon fiber rod. This is a fully carbon fiber system, reinforced with PEEK and some titanium shelling to be able to allow for visualization. So metal fatigues, and we know that from the degenerative literature, from the deformity literature, metal breaks. Inherent to all metal, even the strongest metal or metal alloy in the universe, is fatigue and breaking points. So this should come as no surprise that over time, this will break. And then this becomes even more relevant in our patient population with spinal oncology, because as time goes on, knowing that the likelihood of a fusion is very, very low, the metal will undergo cycling and eventually break. So a desired solution would be to have a construct that can withstand loads in excess of what standard metal constructs do, but also at the same time be radiolucent to allow for upfront fixation. So patients don't end up going to get radiated up front because of a concern for the metal artifact causing the radiation planning to be difficult, but also afterwards, because the imaging is so favorable that radiation therapists can work around the hardware, so to speak, where they can't do that as effectively right now with high Z, high density metal implants. The other thing it does is, to that point, is because of the density of carbon fiber is low, especially as these treatment modalities that involve heavy particles like proton beam become more and more common, especially for a lot of the primary tumors, being able to give patients a lower dose of radiation is really important. And that's related to the fact that the titanium, because of its density, actually bounces a lot of these heavy particles off, and therefore requires that the what's called the Bragg peak, essentially the radiation dose, has to be titrated up to be able to account for the scatter from the metal. And you can imagine, as these heavy particles are being scattered, they're affecting the normal tissue that's being irradiated. So this is the timeline of implants. We've gone from stainless steel to titanium. Now we're talking more about composites. And the biomechanics of composites are really important, because when you look at fatigue strength, the average titanium system usually undergoes around 45 million cycles before it fractures. The human spine goes through somewhere between 2 and 3 million cycles. And so the thought in a standard healthy individual is that they'll go through arthrodesis before the metal fatigues. In a patient who's not going to undergo standard arthrodesis, you're going to need something that doesn't break. And that's the relevance of using these composite type materials. And that's why we don't fly in steel aircrafts anymore. A plane, by virtue of the vibrations of not only the engine, but the air striking it, will eventually fatigue, and the old airplanes used to essentially fall apart midair sometimes. And that's why we're able to fly in airplanes built in the 1960s and 1970s, even to this day. These materials can withstand significant amount of cycling without disruption. So this is to that point again, the typical spine undergoes around 2 to 3 million cycles per year. And when you look at the cycles leading to failure, in general, it's somewhere between 4.3 million and 5 million cycles. With the current implant that's been tested that I've been using, which is the CarboClear CarboFix system, their systems were aborted at 7.7 million cycles. So is this perfect? We don't know. No one's actually tested it far enough out to see if it breaks. But the way that the carbon fiber manufacturing is performed is that individual fibers of carbon fiber are laid down with different vector directionality. So therefore, it's not that it's a homogeneous vector that can eventually, if you fracture enough of the fibers, can break, but that there's opposing and non-correlative vectors to be able to withstand extra load. As far as the imaging goes, I showed you the CT scan. This is what the MRI looks like. You can see very crisp sequences. It's a T1 sequence going through, very crisp outlines of the screw. So relevant for postoperative imaging. The importance, though, with carbon fiber in general is that almost all the carbon fiber systems you see out there will have some degree of titanium, and therefore using a 3 Tesla MRI is not going to be the best option in order to be able to visualize. A standard 1.5 Tesla MRI will give you very crisp imaging. And you can see over here, you may even be asking, where on earth are your screws? And you can see that faint outline of a pedicle screw right there to show what we're working with. And there's the postoperative change right there. There's the CT image. Very crisp outlines. Again, no starburst pattern. And these are relevant because these patients almost all undergo postoperative radiation. Which leads me to the next point, which is radiation planning requires imaging, and requires imaging that is crisp, that is well-defined, and therefore allows the radiation therapists to create very tight boundaries for the treatment volumes, and allows for the spinal cord itself to be visualized and allow the spinal cord to be protected. And this is something that I encountered when I first started practice, was that a lot of patients will come to us through radiation oncology, and a lot of radiation oncologists, especially in the community, will radiate a lot of patients up front, even if they need some separation, even if they need surgery to decompress the nerves or the spinal cord. And the main reason for that is because they don't want to see the titanium. They don't want to try to guess where the spinal cord is. They bear the responsibility of radiation-induced myelitis. And therefore, they're more concerned about being able to see the spinal cord as opposed to try to guess where the spinal cord is around the instrumentation. This is the effect. This is the aspect relative to heavy particle imaging, heavy particle radiation. You can see with a high Z implant, there's about 61% transmission, because about a third of the radiation is scattered away. So tissue is getting doses of radiation that it may not need or deserve. Whereas with a lower Z implant like carbon fiber, it's able to penetrate better and therefore allow for a lower dose of radiation to the tumor. So this study was one of the first studies that looked at that. You can see that there is essentially not a significant difference in terms of the screw, but when it comes to the volume between a titanium screw and a carbon fiber screw, it's significantly less, both within the body and as a whole. And this allows for standard photon radiation doses to be lowered. And in heavy particle, such as protons, this can lead the Bragg peak to be lower. You can see much tighter targets around both photon and proton therapy. So this is what the instrumentation looks like in vivo. This is a patient with a 1-level corpectomy, costotransversectomy through the left, fixation 1 up, 2 down, in the mid-thoracic spine, low SIN score. And you can see the pedicle screw with a titanium shell, polyaxial top-loading system with a rod, essentially a fully carbon fiber system with very favorable imaging characteristics. Intraoperatively, you can see the screw. For those of us who like to see our screws, this allows you to see your whole screw. You don't have to draw a line from a marker to a tulip. You can see actually where your screws go and how they connect. In terms of the modulus of elasticity, the modulus of carbon fiber reinforced peak is the closest thing that there is to cortical bone. Now, this has benefits in terms of stress shielding, but it also has some of the benefits in terms of potentially how much adjacent segment degeneration may be involved, how much how stiff your construct is, and maybe also relevant in terms of how much a necessity there may be for anterior column reconstruction. So I was going to show a couple of the cases that I've done. This is one of the first cases that I did. This is a kind of like a test run, so to speak. It was a 50-year-old lady with metastatic breast cancer to T8, which was incidentally found after she presented with pleural effusions. She was neurologically intact, no mechanical pain. She had mechanical pain related to it as well. She thought that this was relatively just normal for her because of her cachexia and pulmonary effusions. She was noted to have this grade 2 versus 3 epidural cord compression at around T8. We took her to the OR for a separation surgery to allow her to undergo radiation treatment. You can also see this retropleural mediastinal mass on the right side. We followed the MNOP. Again, this talking less about some of the standard workup and treatment pathways, and just more about the technology, but we followed the standard MNOP protocol. She was deemed to be overall pretty stable considering the location of the lesion with epidural compression, intermediate to unfavorable histology, and therefore we took her for separation surgery. And you can see, and performed a strut graft in the front. Cord compression is resolved, but you can also see the spinal cord rather well through the area, which allowed her to undergo successful SBRT afterwards. And the reason to use this technology, the reason that radiolucency is so important, so the biomechanics aside, the reason the radiolucency is so important is because SBRT is playing a bigger and bigger role in local control. You can see that, this study from Tomato was from the early 2000s, and you can see with SBRT, the local control is excellent. Even the ones at the bottom, melanoma and renal cell, they've undergone significant systemic therapy improvements through biologics, and therefore, even those, when we factor in the overall treatment, we're looking at some really good local control. And putting all this together with the Patchel data, patients who get their epidural cord compression resolved, get good local control, not only are able to ambulate longer, they're able to have higher quality of life and maintain continence. So this becomes very relevant. Protecting the spinal cord, whether it's from the tumor encroaching and compressing on it or from the radiation, is very important. And that's where the technology becomes more relevant. Another case, this was actually, I apologize. This was the trial run that we did with this instrumentation the first go around. This is a 66-year-old lady presenting with a breast met to T10. This was identified on PET imaging. She did not have any symptoms, but she was primarily sent for separation surgery. You can see, one would argue not the most impressive of compression, but this would probably be considered an epidural compression grade 1C. You can see that there's a pathologic fracture associated with it. Interestingly, did not have significant compression, even though her SIN score was on the high side of the gray area. I think it was about 12 or 13. So she underwent a separation operation with fixation. You can see just barely the outline of the instrumentation. We were playing with the different rod contours. And you can imagine that unlike titanium, you cannot bend these rods. So have to deal with the different rod contours. So as a trial run, we went relatively short considering the lack of mechanical pain. She is over 1 year out and doing very well. But with her, we also learned that you want to use 1.5 Tesla MR. You do not want to use a 3 Tesla MR because even a little bit of titanium within the shell can make it actually quite difficult to visualize these on MRI. This lady is actually a little bit more interesting. So this is a T8-9, and she initially started off as a T8, but then had local recurrence at T9. Rib head Ewing sarcoma. Presented with some chest discomfort, underwent imaging. A lesion was noted on the right side at the rib head at its attachment to the vertebral body. She underwent a VATS biopsy, which came back as a Ewing sarcoma. She underwent upfront chemotherapy. These tumors are very responsive to chemotherapy. The tumor shrunk, and she underwent an initial T8 to partial spondylectomy, T5 to 11 fixation. This is what her construct looked like. everything was going well. Something happened in terms of her follow-up, and she, I believe, did not undergo post-operative chemotherapy, which is the standard of care for these tumors. And in terms of surveillance, we tried to look to see if the tumor recurred. And I apologize, some of these images don't show up very well, but you can't really see if there's anything going on locally because of all the titanium. There's so much instrumentation, so much artifact. But when you eventually look at her through the lens of a PET scan, you can see that there's a local recurrence adjacent to the vertebral body at the level below at T9. So we took her back and performed a second partial spondylectomy at T9. My thoracic surgery colleagues reconstructed a rib. This is the immediate post-op standing images. So unfortunately, we haven't had any recent weight-bearing imaging. But you can see we replaced her with carbon fiber instrumentation. Her recurrence qualifies her for post-operative radiotherapy now. And therefore, not only does the carbon fiber instrumentation allow for her to get proton beam radiotherapy, but it allows for a better and more crisp way to image her to be able to see if she does have local recurrence. Luckily, she does not have any distant lesions, just a local recurrence that she's had. And you can see a lot of the fresh bone graft on the CT on the right. You can see the imaging is much more crisp through this area. This is her immediate post-op radiation planning simulation images. There's also a potential for cervical fixation. This is the newest cervical plate that's come out. I've done one case with it, so not a terrible amount of experience. The manufacturing process, as I described, is quite high level and requires essentially laying down of the fibers. And the manufacturing process, unfortunately, has not caught up to be able to create any screws under, I believe, 4.5 millimeters. So titanium screws are still necessary to do these. You can speak to the folks from the company, but there's a number of different sizes of plates that are available. This is the one case that I did. This was a very frail 68-year-old lady who presented with a non-immunotherapy responsive metastatic melanoma. She failed all of the more recent biologics that are used to treat metastatic melanoma. She presented with myelopathy. She had right arm pain and weakness. And she had a significant amount of neck pain. She had multiple other lesions elsewhere, but the consideration was for decompression of her spinal cord with the hope that it would improve her overall, at least local control, and maybe increase her KPS to be able to allow her to function better and hopefully undergo more of the multimodal treatment. This is her imaging. It's a little bit off to the side over here. You can see epidural disease, most compressive behind the C6 vertebral body. There's also a degenerative osteophyte there. And this cut is through C6 where there's spinal cord compression. So looking at her imaging, not a significant amount of lysis, not a significant amount of posterior element involvement. The majority of the compression is here behind the C6 vertebral body, despite some degenerative changes. Took her to surgery, did a C6 corpectomy. In the spirit of trying to do this as translucently as possible, I used an expandable peak cage, focused the corpectomy a little bit more to the left side where the majority of her compression was, and fixated her with the titanium screws. And this is what the post-operative imaging looks like. The only thing you really see is some of the tiny markers on the peak cage as well as the screws. And I imagine as the technology and the manufacturing improves, that those screws will probably go on to become also carbon fiber reinforced peak as well. So what are the confounders with these operations? As folks live longer, as radiation gets better, we want to be able to deal with some of these issues that I brought up in terms of wound healing. Being able to operate on folks up front because the radiation therapists are more comfortable working around carbon fiber instrumentation is good, but I think an even next iterative step would be to try to do most of these operations on folks minimally invasively. We're not looking at arthrodesis, so there's there's no real incentive to perform very large open operations exposing a lot of bone surface that we would hope will eventually unite. That stuff is probably not going to happen. I think focusing on minimally invasive techniques, anterior column reconstruction is going to be the name of the game going forward with these, especially as these folks live longer, like Dr. Chapman said, as these folks get better and better systemic and local care. So the potential solutions to helping with those: upfront surgery, carbon fiber instrumentation, composite material, more importantly, anterior column reconstruction, and development of MIS techniques to be able to do these minimally invasively. And with that, I thank you.
Thank you, Dr. Kalani. Outstanding lecture, beautifully done cases. In the chat room, I got two questions. I'll come with the easier first. So cages have traditionally been titanium. PEEK has become a more popular material. Obviously, companies are now coming up with carbon fiber materials. Is there any reason why we should actually use carbon fiber cages over PEEK cages, since they have the same kind of radiolucent properties?
Yeah, I don't think that there's necessary, as far as my understanding is, I don't think that there's any significant difference in terms of load and load distribution. I think the design of the cage is going to be more relevant. I tend to use wide, when I do titanium cases in oncology, I tend to actually use more of like a lateral footprint to be able to get lung hypophyseal coverage with the concern for pistoning. But in a short response, I don't think it makes a tremendous difference. I think there's probably a cost difference that may favor one or the other, depending on your institution. But radiolucency, I think, is the most important aspect, and both cover that. And I think biomechanically, they're probably equivalent.
And that was a big learning point for me from our radiation oncologists. They don't like crosslinks. I'm a titanium person, but they don't like crosslinks over the radiation field. So the second question, we have to kind of rapid fire. I apologize because we're running out of time. Second question is mine. Biomechanically, when you showed the fatigue failure rates of carbon fiber, it's obviously very convincing. But as far as you know, were those composite tests where the screw a rod construct was tested, or were those the rods alone? Because what I thought is those are the rods alone. And the composite testing is not quite as convincing, because the weak spot of this whole assembly is the connection of the screw heads to the rods. So please, could you address that?
Yeah, absolutely. I think what's been tested, like you said, is the composite testing for the rod and for the screw. Of course, the third point of failure is really the screw, two-lobe screw rod interface. And I'm not quite sure. I'd have to get back to you on that. I don't know how much that's been tested or whether that's been tested.
I mean, your images look absolutely beautiful, and there are many compelling reasons, but this is still something that my friends who do these procedures struggle with. Now comes the final coup de grace question from one of our good friends. I'm not going to mention his name right now. What's the longest outcome? What differences do we actually have in terms of survival rates and surgical revision rates for these new biomaterials for oncologic spine reconstructions?
To clarify, is that with the
newer carbon fiber implants? Do we actually have outcomes data, like 2 years outcomes data, that shows a discernible better survival, lower recurrence rates, lower revision rates surgically?
That is a fantastic question. We do not. And the part of it is because it's been so recent. The instrumentation just got approved for an oncology indication, I think like September of 2018. So we just haven't had enough time to look at these. Internally in our institution, we have a database where we're trying to look at whether with the introduction of carbon fiber instrumentation, that the dosimetry that the radiation oncologists are using has decreased, whether the expected volume is decreased, but the issue is just stuff hasn't been long enough to be able to test these. I can tell you that by the nature of a lot of these patients is that they will eventually succumb to their disease. In my personal database of like 30 or 40 of these that I've done so far, not a single person has demonstrated local recurrence. and almost everybody who has passed due to systemic related issues. Most of the younger female breast cancer or patients with renal cell, specifically, very good renal cell systemic therapy. Those folks, I think most of them are approaching over a year so far. But in terms of a robust analysis of how things have changed, if the survivals have improved, if the dosimetry has improved, just haven't gotten that far out yet.
Dr. Kalani, thank you so much for sharing your valuable time with us. This is a beautiful presentation on a difficult subject. We all appreciate the educational merits of your insights and hope to see you soon again. Take care.
It was an honor. Thank you for inviting me.
Thanks for watching. Hit the subscribe button for more medical content.